Okay, thank you. Hello, everyone. So we will get started. Welcome to our Canadian Guidelines for Post-COVID-19 Condition webinar series, or for CAN-PCC. We're very excited to have you all here today for this first session, and we'll get into some introductions. So first off, my name is Robby Nieuwlaat. I'm honored to be your host today, as well as presenter. Joining me are two outstanding contributors to this project as well, Jordi Pardo Pardo and Robert Clifton. And together we will be walking you through the overall methods and structure behind the development of the Canadian Guidelines for Post-COVID-19 Condition, or CAN-PCC. And just a little bit about us so you can better understand who we, the presenters, are. I am the CAN-PCC project co-lead together with Dr. Holger Schoenemann, and I'm an associate professor at McMaster University. Jordi Pardo Pardo serves as the co-chair of the CAN-PCC Equity Oversight Committee and is a senior advisor for the Campbell and Cochrane Equity Thematic Group at the University of Ottawa. Robert Clifton is one of our excellent CAN-PCC patient representatives on the Guideline Development Group, the Prevention of PCC or Long COVID Guideline team, and the Equity Oversight Committee as well. He's also the CEO and Superintendent of Schools at the Nisga'a School District in British Columbia. And here you can see some of our disclosures. Hope that is clear for you all. As we begin, it is important to acknowledge that our CAN-PCC work takes place across Canada, a land that is the traditional, ancestral, and unceded territory of many Indigenous nations. From coast to coast to coast, these lands are home to the First Nations, Inuit, and Métis peoples, who have stewarded them for millennia, and we honor their rich cultures, languages, traditions, and histories. And for our McMaster University presenter specifically, we recommend that McMaster sits on the traditional territories of the Mississauga and Haudenosaunee nations within the lands protected by the Dish with One Spoon, Wampum Agreement. Before we start with the main presentation, we have a few quick housekeeping items for today's webinar. Please submit your questions using the Q&A feature. While we'll try to keep an eye on the chat, the Q&A is your best way to reach us. And wherever possible, slides are presented in both English and French. For most more complex slides, we will present the English first, followed by the French. A recording of the webinar will be available afterwards on canpcc.ca. Probably a few days or weeks afterwards. So it will be available for you to review. All right, so the objectives of this webinar are to describe the overall approach of CAN-PCC, to explain the CAN-PCC methods, processes, and outputs, and to answer your questions in the Q&A. Long COVID, or post-COVID-19 condition, PCC, so we'll use both terms, is a relatively new and complicated illness affecting different parts of the body. What is important to know is that long COVID shows up in different ways in different people and can be mild or severe and lasting for various lengths of time. Different specialties and medical fields are providing care in different places, like clinics, hospitals, or rehabilitation centers. So, which is characteristic of a complex condition. In CAN-PCC, we are applying the World Health Organization's definition of long COVID for adults as well as children. Summarizing the definition for adults, long COVID usually appears within 3 months from the acute COVID-19 infection and lasts at least 2 months. Symptoms can vary and can change or worsen over time and significantly impact daily life. We do acknowledge that other potentially different definitions are available. So long COVID is very common. and around 400 million people globally are estimated to have had or have long COVID. The impact on people in Canada is also substantial, as 1 in 9 adults, or 3.5 million adults in total, have experienced long-term symptoms after COVID-19 infection. And among them, 600,000 missed days of work or school, so their daily life is seriously impacted. Long COVID has been associated with over 200 symptoms and conditions. Among the most common symptoms are fatigue, brain fog, pain in different parts of the body, sleep problems and shortness of breath, and post-exertional malaise. However, many other symptoms can be present, and combinations of multiple symptoms and conditions are common. We have seen, and you have seen, many stories and anecdotes in the media of people sharing their experiences to raise awareness about this condition, and this is one example. Jennifer indicated that this is not going away, and with me being on the wait list for the clinic for over 270 days, that means there is still a need. And this is, again, only one example. I'm sure you've seen many. Jennifer's situation represents the fact that only 1 in 8 adults in Canada who sought support for their symptoms felt they received appropriate care. And the importance of addressing long COVID in Canada has led to investments in research to better understand the condition and find effective care options, such as that for long COVID web. However, Canada's Chief Science Advisor, Mona Niemer, also explained that while scientific studies are undertaken and the evidence base grows to fill knowledge gaps and inform practice, individuals living with PCC or long COVID require care, support, and treatment now. To meet this need, the Michael G. DeGroote Cochrane Canada and McGrath Centers at McMaster University are scientifically and financially supported by the Public Health Agency of Canada to provide high-quality evidence-based guidelines on PCC or long COVID that are easily accessible and facilitate their use in different settings in Canada. So the CAN-PCC's main objectives are to develop Canadian evidence-based guidelines for PCC, to build awareness and facilitate guideline use through knowledge mobilization, and to evaluate the uptake and impact of the guidelines. The CAN-PCC project involves over 150 collaborators. Today, Robert, Jordi, and I present on behalf of the CAN-PCC Collaborative. The various groups involved include people who are health professionals, persons with lived experience, policymakers, health economists, and researchers. And together they bring in expertise in PCC and related care, guideline development, evidence synthesis, knowledge mobilization, and impact evaluation. And I want to emphasize that people with lived experience are considered experts because of that experience. Now, to hear from a person with lived experience who has been an incredible collaborator in CAN-PCC, I want to hand over to Robert Clifton. Robert, please go ahead.
My English name is Robert Clifton. My feast name is Limim Halait. I am settler from Norway on my mother's side and Gitgat Simpshin on my father's side. And as mentioned before, I'm calling in from the Niska territories, which is a treaty nation who signed a treaty back in 2000, so almost 25 years of autonomy and sovereign decision-making in this context. I'm a person who has and continues to live with post-COVID condition. And my, I guess, experience at being one of the initial people who was diagnosed with COVID back in 2020, before even, I believe, BC reached 2,500 cases. Meant that I had an interesting experience navigating both the medical and health systems to receive support for what I was experiencing, including what was mentioned before as incredible long wait lists. I did wait for up to 3 years to be seen by a specialty clinic. My lived experience both in K-12 education and through the pandemic, supporting the education system, students and staff as an education leader, helped contribute to conversations, that were held in all the guideline development team group and the Equity Oversight Committee that I participated in. Including my lived experience as an Indigenous person. So I really appreciated the kind of encouraging and respectful way in which people from lived post-COVID condition were able to really meaningfully participate. As you can tell, sometimes with fatigue, one of the experiences that I suffer is sometimes I can be very articulate and words come out very easily, and at other times I stutter, and sometimes the brain fog creates a little bit of a pause. So bear with me as I make my way through this. So I did participate, like it was mentioned, in 3 groups, both the guideline development group, and we had 2 people with lived experience participating on that development team. In order to both actively and meaningfully participate in that, in the process, we were also did additional training with the grade methodology. And that really did help when we were participating in the entire process. This included reviewing evidence, contributing to those discussions, and ensuring that the guidelines really addressed real world challenges faced by people living with PCC. And also in the participation of my participation on the Equity Oversight Committee, thinking about how we were shaping recommendations that are actionable and considering people who are from equity deserving groups. In the guideline team that I participated in around prevention of prevention of post-COVID condition, it was a very thorough process, which saw people with post-COVID conditions working alongside clinicians, researchers, to ensure that we were developing guidelines that included a holistic approach to supporting people with post-COVID condition. The Equity Oversight Committee really was a variety of people from backgrounds and areas of expertise that participated in thinking how we were addressing disparities in treatment, care, and outcomes for equity-seeking populations, and thinking about how we were ensuring that we were including inclusive practices and equitable access to care. If you move to the next slide, just want to acknowledge the words of my colleague, Kimberly, who was a patient representative who sat with me on the guideline development group. And I just lean back into her words around these guidelines as not just being for people who are patients or people living with post-COVID condition, thinking about how they're using those guidelines to best inform and empower themselves, but also these guidelines developed for clinicians to consider how they are showing up to support those people living with post-COVID condition. And my hope is that these guidelines empower both people living with post-COVID condition, their caregivers, and healthcare providers to navigate post-COVID condition with greater clarity and compassion. And you know, I look forward to the ongoing collaboration that that will continue to bring these guidelines through to its complete publication. Thank you.
Great. Thank you, Robert, for sharing your experiences and insights. Very much appreciated. To explain what the main principles and processes are that we have applied and are applying in CAN-PCC. We use a balanced representation of participants in decision-making roles. As Robert mentioned, he was one of the people who were part of the guideline development group, as well as a guideline team. Including people with lived experience and from equity-seeking groups. And so we also have engagement with key groups and collaborators, including representatives from prominent international guideline development organizations, such as WHO and CDC. We use a transparent and evidence-based systematic approach that is based on best practices for guideline development and including evidence synthesis. We use an independent management of conflicts of interest. This is done by a medical professional organization in Germany that is also developing guidelines and does this independently from our project. And we use and have used standardized training with certification from the International Guideline Training and Certification Program, or InGuide. As Robert mentioned, everyone is being trained in the various steps that are involved in developing guidelines and guideline recommendations, of which the GRADE approach is an important part. And here you can see this in French. So to reiterate, we follow a structured approach by using the Ginn-McMaster checklist. This is a comprehensive list of topics and items that outline the practical steps and tools for developing guidelines. And this was developed by the Guidelines International Network, so GIN, with McMaster University. It also has multiple extensions and translations that are available on the McGrade Center's website that you can see here. Here is that in French. And to elaborate a bit more on those systematic processes, so besides the steps and tools from the Ginn-McMaster checklist, we also apply, as mentioned, the grading of recommendations, assessment, development, and evaluation approach, or GRADE, to determine the certainty of the evidence and the strength and the direction of recommendations. And we will explain a bit more about that today. We also applied the GRADE development approach. This is a term that indicates we first checked for existing recommendations on non-COVID or PCC. If this was available and of sufficient quality, we could adopt or use the recommendation, or we could potentially adapt it or modify it for our purpose and then finalize it. If there's no usable recommendation, which was most of the time in our project, we fully developed the recommendation ourselves. So this is to explain those different steps that are involved in the GRADE development approach. In addition, for our systematic reviews or evidence syntheses, we primarily followed the methods provided by Cochrane, which gives direction for high quality evidence synthesis by international experts. And here in French. So here you can see the structure of the project with the various groups. And you can see, as already explained, the Michael G. de Groot Canada McMaster Grade Centers are the central team. And I and Jordi and several faculty members are on the executive committee that are leading the overall project. We get advice and input from an international advisory board with many international collaborators that we have worked with for quite a while. And this group, with our team at McMaster that is executing and managing the whole project, we also set the scope and focus. And so the guideline development group is the overarching group that makes sure guideline recommendations are being finalized. So they do this based on the work by 6 guideline teams. And these teams also involve various experts for diverse representation. And they draft the recommendations that you have seen in our surveys. We gather a lot of comments. That then goes to the GDG, or the Guideline Development Group, and they review that, discuss that, perhaps suggest changes based on the comments, and they finalize it. This is done for recommendations, and quality indicators will also be added for that purpose. Now, all of this work is based on evidence synthesis, and we have 6 evidence synthesis teams across the world, as well as information specialists in Canada that we work with, that have searched for and prepared the relevant evidence that these guideline teams and GDG have used to make the recommendations. In terms of evidence synthesis, we also had an international group of collaborators that are also working on long COVID guidelines, and we've gathered their input on the evidence that we've identified to ensure there is consistent interpretation of this evidence, and we don't end up with wildly different recommendations across the world. And Canada has a leading role by means of this. Then, to wrap up the structure here, the organization, we have a knowledge mobilization committee. And this is a very important committee that takes the recommendations, creates products for dissemination and implementation, and works with various groups to do specific implementation projects throughout Canada, and we will explain a bit more about that. We also have a public member panel that has been providing input on various aspects and steps within the project. And what is not clearly shown in this graph is that the Equity Oversight Committee, shown here to the side, really was involved in the overall process. So equity was considered pretty much throughout our whole process and throughout our whole project. So this does not clearly enough show that, but it's Jordi will speak to what exactly they have done to clarify that. So to hear from our excellent Equity Oversight Committee lead, who is also on the CAN-PCC Executive Committee, I want to hand over to Jordi Pardo Pardo.
Thank you, Robby. Thank you so much. I will be speaking now about how we considering equity into the whole process of the CAN-PCC. And I will be presenting that on behalf also of my colleague, Tamara Lotfi, that is also the co-chair of the Equity Oversight Committee. So next slide, please. So we follow a 3-pillar approach about looking into equity for the guideline. So first, we just apply an equity lens throughout the whole guideline, and we're going to see a bit more in detail what that means. We also applied some targeted evidence synthesis. So we use the evidence synthesis process as another way of adding information into the equity. And finally, we had the Equity Oversight Committee that allows to provide an overall view of what we're doing into equity. We're going to see a bit more in detail what these 3 pillars mean. Next slide, please. First of all, for the 5 criteria of an equity lens, basically what we mean is that we look into all the aspects that are related into the guideline, and we apply equity on each of them. So from how we set up the priority problem to look whether this is a priority problem for all the disadvantaged populations or not, whether we have a reason to anticipate different effects of the interventions for disadvantaged and privileged populations. And that could be a subgroup effect, but also could be some other element, like, for instance, some groups are disproportionately exposed to COVID-19, and therefore there could be a higher risk of having long COVID. So also all these things that we integrate when we are trying to make our decisions. We also look at whether people there's a disadvantage, how they compare with privileged populations, and whether they have different sets of values around the outcomes or around the interventions that they may prefer one option over the other. We also look at whether there are barriers to implementation. And we also, when we do the evaluation of the guideline, we assess the impact that this recommendation could have onto these disadvantaged populations, or sometimes we may have some impacts that are not expected. Next slide, please. So all these elements are throughout the whole process of the Jean McMaster checklist. And so we apply these principles into all the elements that we are seeing on the Jean McMaster. And we hope that all this experience is going to help develop a new equity extension for the Jean McMaster checklist. Next slide. The second pillar is the target evidence synthesis. And that is basically 7 steps that we use to inform the recommendations. If we go to the next slide. These 7 steps basically lands for first identify disadvantaged populations that we want to focus our effort on, then examine the available data that we are using for the guidelines to see what is the participation of these groups into this data, and use that to evaluate what is the baseline risk, to assess the representation of these groups into the studies, and to appraise the analysis to see if they have looked in particular what is happening with these groups. We also use this effort to note if there are implementation barriers that have already been noted in the studies that we are looking at that. And we also note whether someone has managed to overcome these barriers, or if not, just suggest some implementation strategies to how to go over this. Next slide. So these are the priority equity groups that we have seen in the guideline. The first 3 were set up at the beginning of the document, and the other 6, they have been appearing as we have been working on the guidelines as populations that we felt that there was a need to make some particular emphasis to modify the recommendations. Next slide, please. Finally, the third pillar is the Equity Oversight Committee. And that's a resource that all the guideline teams and committee had in order to see how they will be able to more effectively incorporate equity into the work that they were doing. We also were trying to be coherent how we approach the different aspects of equity around the guidelines. As we have different teams approaching things, sometimes there were different views on how we are approaching things, and the Equity Oversight Committee had the opportunity of trying to provide a more coherent approach on how we're looking at that. And we had a mix of equity-seeking populations, methodologies with expertise of incorporating equity into guidelines and evidence synthesis into the team in order to provide a wide view of how to incorporate equity into the guidelines. Next slide, please. And as Robby was showing, so the Equity Oversight Committee was working in collaboration with all the other committees and groups in order to provide this equity lens in a consistent form all alongside the whole project. And next slide. Oops, I think that's the previous slide. Thank you. So just to say acknowledgements to all the members of the Equity Oversight Committee, and as well as the PHAC team for some of the graphic work that we have shown today. Thank you.
Great. Thank you, Jordi, for walking us through the equity approach and considerations. So to continue with other aspects of our process, prioritizing topics and questions was an important initial step in CAN-PCC. And for this, we performed several steps. So we performed a scoping review of the literature. We organized a project kickoff meeting in 2023 that was open to the public. We shared a topic prioritization survey and a questions prioritization survey after that were both also open to the public. And eventually, using the information from all these steps, the CAN-PCC Collaborative selected the final topics and questions. And here you can see the 6 main guideline topics that are covered in CAN-PCC. Across all topics, we are addressing around 100 questions with guideline recommendations by March 31st. And you can also find the full list of questions that were prioritized in the overall project on our website, together with the graph that you can see here. Now, to show what is involved in creating a guideline recommendation for CAN-PCC, you can see here all the steps by the groups that we previously showed in our project structure. We have received valuable input from the government, patients and public and health organizations who expressed interest in our project, primarily for topics and question selection, and as well as the monthly batches of draft recommendations that we are sharing. All project groups also contributed to these steps, as you can see, and they have further some specific selected roles in specific steps in this whole process, as you can see here. I want to note that in practice, in the longer term, developing recommendations is more of a cycle, whereby, so not as linear as you see here, whereby new evidence may be integrated and the recommendation can be updated if needed. I also want to highlight that throughout this whole process, at several steps, we are translating our products and our outputs and our surveys, and eventually we provide our recommendations and related tools and products all in English and French. And here you can see that in French. Now, to show you and explain how we present our recommendations and related tools, I want to walk you through an example. In this case, the question is, should metformin be used for people with PCC or long COVID who have a new acute COVID-19 infection? The rationale was to address this question as important for practice, as there was experimental evidence of therapeutic doses of metformin in cell cultures and human lung tissue that demonstrated activity against SARS-CoV-2 and showed actions relevant to reducing oxidative stress and inflammation. So perhaps earlier initiation of metformin could result in larger effects, and this is actually also what they saw in the experimental evidence, which supports an antiviral mechanism to its action. So the CAN-PCC groups went through the shown process, all the various steps with those different groups, as I showed you. And the result was this recommendation. In adults with post-COVID-19 condition who have a new COVID-19 infection, the CAN-PCC collaborative suggests using metformin. In between brackets, conditional recommendation, very low certainty in the evidence. The remarks show important clarifications that should always be considered together with the recommendation. They travel together, so to say, and that is why they are displayed in the same box here. And here in French. So how should we interpret the metformin recommendation? First, we always indicate the strength and the direction of the recommendation. The strength can be strong, in which case we would use the term recommend, or conditional, as is the case for this recommendation, and that is when we use the term suggest. Second, we always indicate the direction of the recommendation, which can be for or against the interventional option we are interested in. In the case of the metformin recommendation, we suggested using metformin and displayed the green check mark to illustrate, and I quickly show you that here. You can see the green check mark in the French version. If it was a recommendation against, you would see a red X. And here about the strength and direction in French. Now, what do we mean by certainty of evidence? We specified the certainty of the evidence in the metformin recommendation. Certainty of evidence is also called quality of evidence, and it indicates how sure we are or how confident we are that the results from the review of the evidence comes close to the true effect or the truth. And when assessing this, we express the certainty of evidence in 4 levels. High certainty means we are very confident that the results are close to the truth. Moderate certainty means we are moderately confident that the results are likely close to the truth. Low certainty means we have little confidence and the results may be substantially different from the truth. And finally, very low certainty means we have very little confidence and the results are likely to be substantially different from the truth. For the metformin recommendation, we indicated to have very low certainty in the evidence, which is the case for many of our recommendations. And here in French. What did the CAN-PCC Collaborative consider to come to this recommendation? We structurally considered multiple criteria that are presented as evidence to decision frameworks. These frameworks help to structure the group consensus process. You can see that research evidence is presented, additional considerations are noted, and judgments are made for multiple domains, as you can see here: importance of the problem, desirable and undesirable health effects, certainty of the evidence, importance of outcomes and how people value outcomes, balance of effects, resource use and cost effectiveness, as well as equity, acceptability, and feasibility. Eventually, the guideline developers need to make a recommendation based on all these considerations and judgments. If most of the judgments clearly tip the scale towards one side, it is clear what the choice should be, and a strong recommendation may be provided, as shown in this example. A strong recommendation means that people want to follow it with few exceptions, physicians want to prescribe it, and decision aids are likely not needed, and policymakers want to adopt it and can consider to implement it as a quality indicator. However, if the judgments do not clearly tip the scale towards one side, the choice is not obvious and a conditional recommendation may be provided, as shown in this example. A conditional recommendation means that the majority of people will want to follow it, but they may want to discuss with a healthcare professional first. The majority of physicians will want to prescribe it, but they may want to review all factors first. And most policymakers will want to adopt it, but they may want to review all factors first as well. And here in French. So understanding this, we can go back to the metformin recommendation, and you can see here the overview of the judgments the CAN-PCC Collaborative made for this specific recommendation. This overview was then used to discuss the evidence and the judgments and achieve consensus on the recommendation. And to come back then full circle, these judgments led the CAN-PCC Collaborative to provide a conditional recommendation for metformin based on very low certainty evidence, as you can again see here on the right in the red box. Now we present recommendations in our recommendations map or REC map, which you can see here, and it contains the full information for every recommendation for transparency in English and in French. On the right, you can see the different sections that are presented for each of the recommendations in the map, which also includes a plain language recommendation for patients and the public, as well as justifications, the full ETD framework, evidence to decision framework that I showed you, and other information, again, for transparency. And it's also available in French. The REC map and plain language recommendations are examples of our dissemination and knowledge mobilization tools. These are part of an overall knowledge mobilization strategy that is led by our knowledge mobilization or KM committee. And it involves collaboration and co-design of tools and activities that are tailored to relevant groups that are the, let's say, target audiences of our guidelines. Here we can only give a brief impression of the large amount of work they are doing. The central team at McMaster University conducts webinars such as this one and shares media releases, social media posts, tailored emails to over 300 organizations and over 1,000 individuals, and does outreach to identified health organizations and relevant groups that may be interested in our guideline recommendations. In addition, we have 6 specific knowledge mobilization projects led by the CAM committee members that provide continuing medical education course for physicians, a training program for foreign trained health professionals to reach migrants and refugees, information packages for policymakers, as well as self-management resources, infographics, and tailored videos for the public. So many very different resources for different audiences. And to quickly touch on the third and final component of CAN-PCC, evaluation, we perform impact evaluation by measuring uptake of the knowledge mobilization tools and activities, changes in awareness and knowledge of CAN-PCC, changes in intentions and attitudes, and changes in practice, ideally. For our internal evaluation, we always aim to do, which we always aim to do for guideline development projects, we evaluate our processes and methods with our collaborators, so we can improve also going forward. And as an important and final note, I'd like to emphasize that the CAN-PCC structure and transparent reporting, as you could see, allows for adaptation of the recommendations for other contexts and for continuous updating going forward. For example, some of our international collaborators have used our list of prioritized questions, some of our evidence or full information from the evidence to decision frameworks to help them make decisions for their own guidelines in their own context. In addition, the emerging evidence on PCC or long COVID can easily be integrated and recommendations can be reconsidered or updated as needed based on everything that's been set up. And to highlight some resources here for the patients and the public, you can visit our website to assess self-management tools, infographics, and short videos to help you understand what we are doing and what we are sharing. For health professionals, there's a dedicated section for you as well on our website with various resources. For policymakers as well. So we want to thank the CAN-PCC collaborative and group members for their incredible collaboration to do all of this work that is still ongoing until the end of March. And we also want to thank patients and members of the public, health organizations, the Council of Chief Medical Officers of Health, and federal and provincial tables for their valuable input, and the Public Health Agency of Canada's PCC Secretariat for their great collaboration. This large collaboration and the dedication of everyone involved help to provide and disseminate highly needed guideline recommendations. And it also highlights important gaps in research, and it will be an important contribution to advance the care for people with long COVID. So thank you all again. And then I think we can go to some questions. So let me check which questions we have. Okay, so I will read out the questions and we'll try to answer them as good as possible. If perhaps Jordi and Robert can help, then we can do that as well. So the first question in the Q&A here asks whether any therapies for brain fog or major loss of smell and taste, I guess, are addressed in the guidelines. So we do have questions for management of brain fog and also smell therapy. We have a recommendation about smell therapy. I won't go into the details of these specific recommendations, but they are available on the recommendation map if they are still in the final stages of being, before release, being finalized based on all the feedback that we've received, they will be on the recommendation map soon. But yes, we are addressing that. If the next question, Jordi, if you want to contribute, go ahead.
No, I was just going to add that if you go to the CAN-PCC rec map, you can check yourself what are the recommendations on these topics, and you can easily make a search for any word that you're interested on, and it can give you what is the answer.
Yeah, I agree. Thanks, Jordi. The next question is, if guidance has been created and written, how is it re-evaluated after publication if there are errors or a change in evidence? This is a great question, and I think I at least partially addressed it with one of my final slides there. But to reiterate, again, the full information we've provided allows for searching for and adding new evidence and updating recommendations. After publication, so I want to emphasize as well, we are publishing our recommendations on the rec map as we go. So we haven't been waiting for, let's say, a manuscript. Now, in the end, there will be a manuscript or several manuscripts published. But the whole purpose of this process and these tools is that we can now continuously, or as often as needed, update the evidence and thereby the recommendation if needed going forward. So yes, this will be possible. And then the next question is, I guess it's somebody sharing their experience. It's someone admitted to hospital with 20 different symptoms or multi-organ system failure, discharged with no diagnosis. How do we better educate all doctors? Now, I think you can see from the objectives of CAN-PCC, we are aiming to provide guidance, as Robert also reiterated, for health professionals, healthcare providers, in addition to also, of course, the people with lived experience and policymakers. Education based on the recommendations that we create is a very important part of our knowledge mobilization strategy. And as I've quickly touched on, is we do provide resources also for healthcare providers to better understand what our recommendations are, what they mean, and perhaps how they can be implemented in practice. We also have a specific recommendation actually on structured education for healthcare professionals. And I also suggest that you look at that on the rec map. Okay, so these are relatively short answers to some of those questions. Of course, there are a lot of details we could go into. As you hopefully understand by now, it's a large project with many moving aspects, many recommendations. But please do ask any other questions that we are happy to answer as good as we can. Quickly checking the chat here. Okay, well, as we're perhaps waiting for some more questions to come, just want to check. Robert, is there anything else you would like to share at this stage?
No, my second cup of coffee hasn't kicked in yet. Good, thank you.
Thanks, Robert, and your experiences and your explanations were very clear, I think. Jordi?
I just appreciate just sort of being included in the presentation, and thank you for bearing with me as my brain warmed up, because I'm on the West Coast. Sometimes it takes a little while. Thank you again.
Thank you, Robert. Jordi, do you want to add anything else?
No, not so much to add. On the question about what we need to do to educate all doctors, I will just to highlight how difficult it is to do that. So that's long COVID is one disease of thousands that are out there, and just keep everybody updated on everything all the time is very, very complex. And I think that it's a matter of saying there is no magic bullets, but there is the effort that we can just do and keep the drop of water keep going on until it finally goes through, and it's getting the conversation around and the awareness about the different conditions that could trigger people to be curious and look for options, and then having the resources available to inform. So I would say, I think that we all need to take our responsibility on what we can do to help, to point people to the right direction for the different questions.
Yeah, thank you, Jordi. Important point. I think we indeed have to be understanding and compassionate, of course, for people who are experiencing long COVID PCC as they are trying to navigate and getting appropriate care, but also for the healthcare professionals and providers who often are also not sure what they can do. And so as we are sorting that out with our guideline recommendations and ongoing primary research, we will, bit by bit, we will need to get there. And in terms of educating them and making sure they're up to date on the most recent information, is indeed that takes long-term efforts, repeated efforts, and make sure it integrates into their practice as good as possible, because often they are very busy clinicians as well.
One thing that I wanted to say that I think the guidelines are really helpful with, and this conversation that we've talked about several times, is around ensuring that the recommendations will help with people living with post-COVID condition be able to advocate for themselves and ask the kinds of questions of their health practitioners and clinicians in their quest to seek care that addresses the experience that they're living with. And that's one of my reasons that I wanted to participate, because I've had a lot of interesting experiences navigating the medical and health systems, and do believe that those guidelines will help people living with post-COVID conditions have those kinds of conversations that gives them agency over the care that they're seeking. Thanks.
Great, thank you, Robert. And indeed, patients and their caregivers can use our resources to take to their providers. And I want to emphasize, as many of our recommendations are conditional recommendations based on very low or low certainty of the evidence, is that shared decision-making and trying to discuss this with your providers and your healthcare professionals in general, it is really needed and valuable to make sure you can make the best possible decision, often because you don't have, let's say, the highest certainty evidence. And factoring in, considering your values and preferences with that is essential. Okay, great. So I'm trying to check here. I don't think we have additional questions coming in. Ashley, can you confirm that?
Yep, no more questions coming in.
Okay. Then I think we can wrap up the presentation. I want to thank everyone for joining us here, and the recording again will be available afterwards for anyone to review. Especially thank you to Robert and Jordi for joining here and explaining this. And please keep an eye out and register for the next sessions and presentations in our webinar series. We as the central team are setting up a series of presentations on the various topics that we've shown you. And there are also other groups that are doing KM work and doing webinars. So please check out our website and our posts and notifications to stay up to date and attend as you want. I'm seeing something on screen here. I'm not sure how it ended up there. Perhaps this is a question. Okay, let me see if I can read the full question. One ER doctor told me his job was not to diagnose me, but to only keep me alive for 24 hours. That sounds like a horrible experience, and I think this would then be a healthcare provider who not only needs education on our recommendations, but perhaps also in terms of how to treat the whole patient and listen to the patient and take them seriously. That's all I want to say about this specific example. All right, thank you everyone, and hope to see you in some of our next webinars. Take care.
Thank you.